Good evening, everyone. It is with immense pride and pleasure I invite all of you to another illuminating chapter by Team CM, your partner in learning. So to all our dear members who have been with us from the first session, welcome back. And we are equally excited to welcome all the new members aboard Team CM. In this series of webinar from October 5 to October 11, we hope to present to you a comprehensive understanding of the concept and management of Shirorogas. But before we go into the management, what has Acharya told us? Rogamado parikshe tado anandaram aushadam. So the first step, that is the clinical examinations of ENT, head and neck, will be taught to us by Dr. Jinesh J. Menon, sir. About Dr. Jinesh, sir, is a bright young Ayurveda doctor hailing from Kerala, who started his love for Ayurveda from Vaidyaratnam Ayurveda College at Ullu, and did his MS in Chalakya Tantra from Government Ayurveda College, Tripunithura. Sir has secured the first rank in the 2012 Kerala PSC and is presently the MO at Government Ayurveda Dispensary in Idukki, Kerala. With utmost honor, I welcome you to conduct this session, sir. I welcome all our dear participants to engage, interact, and make this a very fun learning session. Thank you, sir.
Hello, good evening, everyone. And first of all, let me thank the team CME for inviting me for this session again. We had the same session some 6 months back. And to be precise about the topic, we are going for examination of ENT, and the people who are conducting this class had actually informed me to include examination of scalp also, but I think that is beyond the scope of this single session. If at all we are doing an examination of scalp, we will do it as a short session on another day. So let us start with the examination of ear, nose, and throat. So ear, nose, and throat is called as a single unit of ENT in terms of disciplines of specialty in modern medicine. Whereas in our perspective, also from the perspective of Ayurveda, these three are also connected, well connected, as we shall see simply because of anatomical connection of the nasal cavity to the nasopharynx, oropharynx, and to the paranasal sinuses, and also from the nasopharynx, there is a connection to the middle ear, which is called as the eustachian tube. Hence, any problem affecting the nasal cavity can affect the middle ear, and it can cause pathologies in the middle ear. We will see the pathology as a pain of the ear or a discharge from the ear, but we will have to treat for the nasal cavity and even to the oral cavity in order to cure that particular condition of the ear. So coming into the examination of nose, we are not directly going into the pathologies. We will go through the examination. Examination of nose includes anterior rhinoscopy, posterior rhinoscopy, and for the investigations, basic investigations for X-ray skull lateral view for the view of adenoids, X-ray PNS waters view for the paranasal sinuses and DNS and polyps and all other problems of the sinuses. And then even a higher investigation is CT PNS osteometal view for further details. And examination of PNS, we will be doing a live demonstration after the slides. So let me talk about this first. Eliciting tenderness of maxillary frontal and ethmoidal sinuses. That is the first point of examination of paranasal sinuses. Now, a short brief anatomy of the nasal cavity. You can see the nasal cavity, nasopharynx, oropharynx, and from the nasopharynx you can see the ears through eustachian tube is present, which connects all these three structures, and the oral cavity is still very close. This is the anatomy of the nasal cavity. If you are looking from the lateral part, you can see these bones, and if you are looking from the anterior part, you can see on the left lower part that particular picture shows the nasal septum, and the turbinates. There are three turbinates, as all of you know: inferior, middle, and superior turbinate. And the space behind or below those turbinates are called as meatus. Inferior meatus, middle meatus, and superior meatus, in which to the middle meatus, most of the sinuses are opening. So that particular area is very important because the opening of the sinus is called ostia, and if that ostia is blocked, there will be chance for fluid collection in the sinuses, and that will cause much problems with the nasal cavity and the diseases of the nasal cavity. You can see the septum and the turbinates. The turbinates are actually bony structures covered with mucosa, and actually the bone cannot enlarge, or usually it cannot cause a hypertrophy. So what is actually turbinate hypertrophy is the hypertrophy of the mucosal covering of these bones. It happens cyclically in normal physiology, as well as mucosal hypertrophy of the turbinates can be happening as a part of allergic reactions also. These are the three turbinates from the lateral view. These are the sinuses. You can see the frontal sinus, maxillary sinus, and ethmoidal sinus, and the connection to the middle meatus of the maxillary sinus is very evident. These are some physiology. What are the relevant physiology of the nose? The basic physiology, I am not reading all these lines. The basic physiology is the temperature regulation, and the nasal hairs are there that is to filter the dust particles and any other thing. Before the air is going into the nasal cavity and the lower respiratory tract, the air temperature should be controlled. That is the primary function of the sinuses and the mucosal lining of the nasal cavity, and even the upper, the whole upper respiratory tract. And ventilation and drainage of the paranasal sinuses should be proper. For that, it is designed by the God these beautiful. Hello, am I audible? Am I audible?
Yes, yes, sir.
So the ventilation and drainage of the paranasal sinuses is very important, and these concave or these turbinates are designed in such a way that when you're inspiring, the air is going into the nasal cavity. During that time, the air from the sinuses comes out, and when you are expiring, during exhalation, the air goes into the sinuses. That is the particular design of these turbinates, so that the air and ventilation of the sinuses will be proper. If this is not proper, the mucosal lining of the sinuses and the ciliary movement of the sinuses will be affected, which will hamper the excretion or expulsion of the fluid from the sinuses. And once the fluid is mucosa or fluid is getting accumulated in the sinuses, that is going to trouble you. Olfaction, vocal resonance, and nasal reflexes like sneezing, all are the functions of nasal cavity. We all know. This is also explained because of a negative pressure and a positive pressure during exhalation and inhalation, how the sinuses are being ventilated. And that is also helping in the ventilation of the sinuses, as well as the mucosal ciliary movement and expulsion of the fluid. Nasal cycle, as I already told, that the mucosa will be rhythmically cyclical congestion and decongestion will be happening through the nasal chambers. So sometimes patient comes to us and they will tell us that there is something inside my nose, there is a polyp. Even for the terminal hypertrophy, local people use the term polyp. And even doctors use the term polyp for terminal hypertrophy. And there are doctors who do surgery for the terminal hypertrophy also. That is not totally out of the way. There are cases in which the turbinates are being removed in many cases, but it is a very useful and needed part of the nose that should not be removed at likewise a polyp, because a polyp is a totally unwanted foreign body that is obstructing and causing troubles, whereas the turbinates and the mucosal lining of the turbinates, and even if it is hypertrophied, that is very much needed structure. So when such patients are coming, you should always bear in mind the fact that there is a chance that the mucosal congestion will be normal. Physiological congestion of the nasal concha, also called as nasal turbinates, due to selective activation of one of the half of the autonomic nervous system by the hypothalamus. This should not be confused with the pathological nasal congestion, which can be seen even in CT scan also. You can see here the congested side is the left side. That is on the screen, it is on the right, whereas actually it is the left side of the patient. Here the terminates are hypertrophied. You can see in the CT also. In this particular CT, the right inferior and middle turbinate of the patient is congested. But after 8 hours, if you repeat the CT, the same congestion will be seen on the other side. That is exactly called as a pathological mucosal congestion. That is very much normal, and it need not be adverse for any treatment. This is the mucociliary blanket of the nasal mucosa, and also inside the paranasal sinuses. Such mucosal ciliary movements are already helping in the fluid expulsion that we already discussed. Nasal passage narrowing is the main problem the patient will be presenting to us. Presenting complaint will be this one, nasal passage narrowing. The causes can be deviation of nasal septum, chronic allergic rhinitis, and that will be causing mucosal congestion, the turbulent hypertrophy, and apart from that, the real foreign growth that happens there is a nasal polyp. There is also another condition called as congo-bullosa, whereas the turbinates will be filled with air. That is also called as congo-bullosa, but if it is also considered as normal, if it is not causing a permanent obstruction, that is also considered normal. And if it is not responding to the conservative management, sometimes it is removed surgically. That can cause a DNS to the opposite side also. For example, if there is a congo-bullosa or the turbinate is filled with air, or it is hypertrophied in such a size that it pushes on the nasal septum, then the nasal septum deviation can happen over a period of time. As I said, if it is causing obstruction, it needs surgery. This is called as congo-bullosa, in which the middle turbinate on the left side of the patient, you can see air inside the turbinate. These are all the part of management which is beyond the scope of this class. I am skipping those. Deviated nasal septum are of 3 types mainly. It can be a C-shaped, which is you can see on the right side in the first row, and there is an S-shaped one, and the third one is the spur-shaped. The last, but on the right, is the septal thickening of the nasal septum. That can also cause an obstruction because it can cause the reduction of space between the turbinates and the nasal septum. As you all know, medially there is a septum, and the turbinates are arising from the lateral wall of the nasal cavity. So there is a gap between these two through which the air has to go. And if the gap is too narrow, these two can touch each other. That will cause irritation. If the gap is too narrow, again, any dust particle can get trapped there and cause irritation, and that will also trigger an allergic reaction. There is something called as nasal packing. We used to manage anterior nasal cavity bleed or epistaxis. That is not in our scope because that is being done by the modern ENT practitioners. Whereas in our case, there is a condition in which we just discussed, where there is nasal passage narrowing due to turbinate hypertrophy as well as due to the DNS. In both these conditions, nasal packing with gauze soaked in Morivana for 1 hour per day, from our experience, it is very useful so that the passage somewhat opens up. Maybe there is a DNS and the DNS will not be cured 100%, but definitely the passage will be somewhat patent to such an extent that the patient's symptoms will be relieved. And also along with this, we will be going definitely with our internal medicines. So nasal packing for DNS, we will be using Morivana and gauze. We will be making a wick with the gauze. Then that will be soaked in the somewhat hot Morivana. This is a case of DNS. This is the nasal packing. We will be doing a demo on this. Actually, this case is a case of DNS, but the packing is done in another case of turbulent hypertrophy. After the packing, immediate relief of the size of the turbulent hypertrophied turbinate was observed, but not in all cases we will get sudden result. But definitely in DNS and turbinate hypertrophy, this nasal packing is very much effective and useful. Also, there is no need that the physician should always be there. We can educate the patient, and the patient can do themselves in their home. Differentiating a nasal polyp and a turbinate hypertrophy, that is very important, because for the patient, the turbinate hypertrophy or the polyp, everything is called as foreign body, or you call it a polyp itself. So you can see this. This is the right nostril of the patient. On the right side is the septum. On the left side, the pink colored one is the inferior turbinate, whereas the other pearly colored whitish mass is the polyp. There is a lot of difference between the polyp and the turbinate in appearance itself, so that we can easily diagnose on examination. This is another case. Here it is in the right nostril. You can see on the left side is the turbinate, on the right is the nasal septum. This is another nasal polyp, and you can see the difference in color and appearance. For the nasal packing, we are using an instrument called as Tilly's forceps. Also, for the anterior rhinoscopy, on the left is the tudicum nasal speculum, and for the throat examination, we will be using the tongue depressor. These are all instruments for the wax removal from the ear. Now, we will be going into the ear examination. Before that, we will do a demo on the examination of the nose, in which the examinations which we simply can conduct in the clinical setup will be discussed. So I hope all are comfortable with the video. And is the video clear? I will my video so that everyone can see.
No, sir.
Hello?
Hello, sir. Video is not shown.
No. I mean, you can hear me on Ginesh 2. I'm speaking from Ginesh 2. Otherwise, we will directly go from the video from this one. Is it clear?
Okay, sir.
Hello? Now you can see clearly, right? Hello?
Yes, sir. Yes.
Okay. So here is our demo patient. So first of all, we will be going for anterior rhinoscopy. Now you are expecting the external nostril. We will be holding the tip of the nose like this for examining the nasal cavity, and ask the patient to tilt the head upwards slightly. This is exact position. Hope it is clear.
Yes, sir.
We will be examining both the nostrils separately, and we will be able to see inferior turbinate and the middle turbinate from this point. And now we will be doing anterior rhinoscopy. To become nasal speculum. Before introducing the nasal speculum, we have to just hold like this, and we will be inserting inside. For examination of ENT, definitely you need a headlamp, which is available for 300 rupees from the Flipkart and Amazon nowadays. This is an one from the old school. So we have a headlamp, and now we are going for anterior rhinoscopy. We will be going inside like this. Once you are inside, you release the speculum so that more area of the particular nasal cavity can be seen. Okay, before pulling it out, again we have to press and bring the blades together and pull it out. But before pulling out, never bring the blades so close like this. That is always wrong, because one or two hairs can be trapped inside, and when we pull it out, the hair will be coming out with this, and there is every chance that the patient may slap on our face, because it is very, very, very painful. We are again going for the other nostril. And again we are releasing. I can see up to the middle turbinate. And now slightly I am pressing the blades so that bring it together and pulling out. So we can actually insert it like this, vertically as well as horizontally. This is also possible. This will give another view. This is all about anterior rhinoscopy. And beyond this in middle turbinate, if you want to see, then we will have to go for endoscopy, nasal endoscopy. And now the examination of paranasal sinuses. Simple techniques are there, like we can give a sharp light onto the maxillary sinus like this. And if the sinus is patent, you can see the light from the oral cavity. This is we cannot show the whole thing on the particular mobile video, but that is the technique called as illuminance, transilluminance of the sinuses. So that if the light we can see from the oral cavity, that means that the there is no fluid in the particular sinus. And also the same can be done with the frontal sinus also. If you're giving a light here, and we can see the illuminance in the frontal sinus. Now the tenderness of the sinuses. Here we will see the tenderness of the maxillary sinus just above the canine teeth. And we will never ask the patient if you have pain or not, because if there is pain and sinusitis, patient will definitely wrinkle the head, or there will be signs of pain on the face. From that itself we can assess. Now we are going for frontal sinus. We will be pushing up from the base of the frontal sinus like this, upwards, both sides. And whereas we will be pushing towards the part of the nose, medially, to elicit the tenderness of the ethmoidal sinus. Hope it is clear.
Yes, sir.
Okay, so I am again going for a screen share. So now we are going into the examination of the ear. 1 minute before proceeding to the ear, the posterior nasal cavity should be seen. For that we have to use posterior rhinoscopic mirror, and many a times it is not a very easy procedure. It can be done by a specialist only. Also, due to the gag reflux, sometimes we will have to use the xylocaine spray. So generally, if there is any pathology we are suspecting in the posterior nasal cavity, we also advise the patient to have an endoscopy or a CT or even an X-ray, lateral view of the skull, so that usually the pathologies in the posterior nasal cavity coming to us will be of the adenoid hypertrophy in children. That can be almost clear from an X-ray lateral view of the skull. Now, examination of ear. Part of the ear from the outside is pinna, then the external auditory canal, then the tympanic membrane. The examination is simple torchlight light examination, otoscopy, and also there is a technique of endoscopy. This is the normal ear canal. Normal ear canal can be seen. What we will be seeing with the view into the ear canal will be the wall of the ear canal and the tympanic membrane. So for this, we have to use two techniques in adults and children. In adults, we will be pulling up, upward, outward, and backward. The pinna should be pulled upward, backward, and outward so that the canal will be straightened and we can have a good view of the tympanic membrane. Whereas in children, it should be pulled downward and backward because the canal shape of the canal is different in the child and the adult. This is what is written in the next slide. Pull pinna out, upward, outward, and backward in adult, down and back in children. This is another example of inflamed tympanic membrane. Here, the tympanic membrane, you can see that it is very much congested. It is also retracted inward. That can be better evident after you see the normal TM. This is the normal tympanic membrane in which it is not at all congested. It is pearly white and there is a cone of light. You can see a cone of light just behind the handle of malleus. This is the normal right and left tympanic membrane. These are the parts. You can see the lateral process of malleus. Pars and pars placid are the two parts of the tympanic membrane. And the cone of light you can see on the picture on the inferior part of the tympanic membrane. If the cone of light is present, if you will write it in the prescription as tympanic membrane seen with all normal landmarks. The landmarks are these four parts. So this is the an example of an abnormal TM in which the TM is congested. Also, it is retracted inward. There is no cone of light visible. And vaccine external auditory meters, first of all, we will do an examination according to the protocol, that is pulling outward, upward, and backward. Then we go for a torsional examination. You are not visualizing the tympanic membrane, and you are visualizing something else like a black color, maybe black, maybe brown. And the patient is also having a feeling of closed ears, and sometimes there will be pain. All these point towards the presence of wax in the external auditory meters. The wax, we can remove the wax with the instrument called as Jobson's horn probe that we will show. And also in some cases, the wax will be very hard. In that cases, we will have to use some kind of snehas like Shardala for some few days, and then the wax will be loose, and after that we can remove. In still in some advanced cases, there will be hard wax locked in the isthmus of the external auditory meatus that we cannot remove. That can be removed maybe under local anesthesia under the microscope. That is in the setup of a surgical theater. This is another example of a retracted tympanic membrane. The tympanic membrane has a positive pressure from both sides. There is a pressure from the outside through the external auditory canal, whereas there is a pressure from the eustachian tube to the middle ear. These two pressure balances, and then if there is a perfect balance, the tympanic membrane will be exactly like what we see in this case, normal. But if the middle ear, the eustachian tube is blocked and the middle ear has a negative pressure, then it pulls the tympanic membrane inside towards the middle ear. That is exactly called as retracted tympanic membrane. Once the air fluid inside the middle ear is used up by the tissues, then the mucosa will start secreting mucus. Then the mucus will be collected in the middle ear. That will, if it is not treated timely, that will turn into pus. Then the pus will cause a rupture of the tympanic membrane and the pus will flow out to the external auditory meatus. The whole process is called as acute otitis media, and once the pus is coming out, that is called as perforation of the TM, and once the same condition is chronic, it is called as chronic subpruritic otitis media. Whereas the initial phase of this is simple collection of fluid inside the middle ear, which is called as glue ear. This is another pathology of the tympanic membrane where there is bullae are present on the tympanic membrane. You can all know that bullae is some fluid-filled lesions on the skin. It is very much common in dermatology. Such lesions, if it is coming with the inflammation on the tympanic membrane, it is called as bullous meningitis. So these are the examination of physical examination of the ear. Then we will again go for the examination of ear. Hope again you can see me. Ask the person to turn up to the right. Okay, the instruments used are obviously otoscope. This we will not be using now, but this is the Jobson's phone probe for removing the wax. Then, of course, we need a tuning for assessment of ear. So first of all, there is a simple technique of total examination of the ear. Here we are examining the right ear of the patient. First of all, look on the pinna for any kind of masses, or if there is any vesicles, erythema, or tenderness. Now we are going to examine the external auditory canal. Since this is an adult patient, we will be pulling outward, upward, and backward, so that we can see the tympanic membrane. In this case, in this particular position, I can see the cone of light. Now I cannot see, but in this position, when I pull outward, upward, and backward, cone of light is easily visible. If you practice in at least 5 to 10 patients, you can also simply assess the condition. Now, examination of the auditory canal with the otoscope. Otoscope you should be holding always like a pen. Sometimes you will be holding like this. Also, like this, it is wrong. Simply one hand is needed to hold an otoscope. It will be held like this, so that the other hand we can use to pull the pinna. As I said, outward, upward, and backward. Now we pull the pinna and straighten the canal, and then we are introducing the speculum like this. And we are looking into the ear canal. So in the case of this patient, the tympanic membrane is normal with all landmarks. There is no erythema signs of inflammation or any mass in the external auditory meatus also. This is the basic examination of the ear. And now about if the patient is complaining of feeling of a hearing loss, or there is a feeling of blockage in the ear, we have to check if there is a conductive or sensory neural hearing loss. For that, we need a tuning fork. This is tuning fork is 256 hertz. We just have to give it a vibration and ask the patient if he can hear. Simply, we can use to compare the hearing on the both sides for a gross comparison. Now there are 3 tests: absolute bone conduction test, Rini's test, and Weber's test. Actually, ideally, these tests should be conducted in a room which is insulated, so that the other sounds should not be coming inside the particular room. We are giving a demo in this particular case just for your understanding. So ABC is absolute bone conduction test. Absolute bone conduction test means you know that the conduction of the sound happens through the auditory canal, through the air. It hits the tympanic membrane, and through the ear ossicles, it transmits the sound as vibrations to the inner ear. So the bone conduction is bypassing this external auditory meatus. Directly the sound given to the bone, that is on the master process, we are putting the sound vibrations that will directly go into the ear ossicles and then to the inner ear. So even if the conductive mechanism is not working, the air conduction is not working, the patient will be able to hear. If there is conduction means that the bone conduction, if it is normal, we can assess that through bone conduction. Just for information, again, we are giving a tap to the tuning fork. We are putting it on the mastered process of the patient. And once the patient stops hearing, ask the patient to raise the hand. When you stop hearing, raise the hand. Are you hearing now? No. You can hear. Even after you stop hearing from the back, now you can hear from the front. So this means that simply the air conduction is greater than the bone conduction, and that is normal Rinne's test. You have to compare both sides. You have to do it in the both sides. Now the absolute bone conduction test is simple. We will be comparing with the examiner. Means once the patient stops hearing, ask the patient to raise the hand, and then I will put it on my mastered process. And if I am hearing, then it is represented as less than the examiner. And if she stops hearing, and if I cannot hear, the test is negative. And now the other one is the Weber's test. Weber's test is used to assess which ear is having the problem. Both conductive hearing loss and sensory neural hearing loss. Both these conditions, we have to use the Weber's test. Now we will be giving a tap and putting it on the vertex. Where are we hearing? Both sides or on the center. Okay. On the center. So here the patient is able to hear on both sides equally, so that the Weber's test is central. Weber's test central means there are two possibilities. It is one possibility is that the patient's hearing is very much normal. The other possibility is that patient has a hearing loss of equal magnitude on both sides. Both these can give Weber's as central. And Weber's can lateralize to one side. If, for example, if you have a sensory neural hearing loss on your right ear, that means one way or the other way, you are not going to hear on the right side because your neurological mechanism is so your neurological mechanism of the right is gone in sensory neural hearing loss. And when you put the Weber's test on the vertex, definitely you will be hearing on the better ear. So in case of sensory neural hearing loss, Weber's will be lateralized to the normal ear. In conductive hearing loss, what happens is that Weber's will be lateralized to the affected ear, because suppose I have a conductive hearing loss on the right side, so that my air conduction is poor. Air conduction is poor means through bone I can hear, but through my auditory ear canal, through the air, I cannot hear. So when I am putting this on this side, on the normal side, conduction will be there through the bone as well as the air. So it will be somewhat disturbed. Whereas on this affected ear due to conductive hearing loss, I will not be able to catch any sound from the outside from the air, but I will be hearing clearly the sound through the bone conduction. So in conductive hearing loss, the Weber's will be lateralized to the affected ear. In sensory neural hearing loss, Weber's will be lateralized to the normal ear. Now the examination of throat. Throat means oral cavity. It starts on the lips. Then there is the buccal cavity. Also oropharynx, the floor of the oral cavity, gums, and the teeth. Because we are examining the oral cavity, a totality should be there. We will be just covering all these aspects. So first of all, look the lips from the outside for the if there are any cracks on the lip, if there are any signs of cyanosis, all those are part of general examination. It need not be explained in the ENT purview. There is something called as the maxillary labial frenum mucogingival line. The gingival line recedes in cases of bad health of the gums. Once it recedes, it cannot be, it will not come back. That is what modern medicine says. But in our experience, with our treatment, it sometimes gets better also. So hold the tongue with the gauze and use a tongue depressor to see the oral cavity. That means the uvula and posterior pharyngeal wall, and also the tonsils. Whereas if you are examining the base of the oral cavity, ask the patient to retract the tongue to see the floor. Now the oral cavity examination, here it is as spatula is being used. We can use the tongue depressor made of steel also. Any missing teeth, dental caries, ulceration, hemangioma, these are all known to all of these who are the audience of this particular class. If there is halitosis, a tongue depressor, inspect the tonsils, uvula, and the sauce palate. Ask the patient to tilt their head upwards to inspect the hard palate. These are all simple, logical things. Now you have the hard palate, there is soft palate, uvula, the anatomical structures, palate and tonsils, and the tongue. The normal tongues should be examined in every patient, because sometimes patient comes to us telling that there are some red spots on their tongue. In 90% of the cases, this will be normal papillae of the tongue, but the patient does not know if that is normal or abnormal. We have to see and have an observation of the normal tongue in so many patients, so that we should be able to tell the patient that that is normal. What are the signs we can see in the oral cavity? Obviously, ulcers, presence of ulcers, tonsil. Is it hypertrophied? Is it just hypertrophied, or is it inflamed, or there are pus or crypts, like stone-like yellow things are seen on tonsils? Now the posterior pharyngeal wall, is there a congestion? Presence of congestion is there, and whether the glands are congested also. Other than the tonsil, there are a lot of other glands on the posterior pharyngeal wall. If those are congested, then there is an important point in this particular clinical condition, because that can be a part of an upper respiratory tract infection, the congestion of the tonsils and the posterior pharyngeal wall. Also, from the perspective of our concept of costa, if there is regurgitation, the gastroesophageal reflux disease, GERD, and on the upper part of the GA tract, it can cause LPRD. It is called as laryngopharyngeal reflux disease. This can also cause posterior pharyngeal congestion and even tonsil hypertrophy and inflammation. And in some patients, this can this particular condition cannot be treated like an upper respiratory tract infection. Whereas you have to correct the costa and look into the GERD or this Samprapya Budavarta to control this particular condition. Anti-allergic or anti-inflammatory medicines will not work from the perspective. For this particular condition, there is a scoring in allopathy, in which the GERD will be assessed with some 20 criteria, and if the score is above 10, then they come to a conclusion that this particular patient upper respiratory infection is due to the reflux disease and not due to allergic reaction. And you go into the buccal mucosa and the wall of the buccal mucosa. If there are any mucosal cysts can be there, and if there are any color changes, any blackish discoloration, very commonly in OROP we can see lichen planus, oral lichen planus, OLP. Now this is the normal appearance of the tongue. You can see big papillae beyond the terminal sulcus, close to the posterior part of the oral cavity, and just anterior to the or proximal, distal to the terminal sulcus is the normal part of the tongue, where you can see the well-light papillae. These are very small in size, and sometimes in some patients this papillae will be seen as raised. That is, they will be seen as elevated from the normal level surface of the tongue. That is also somewhat normal, and after some time it will go to normal by its own. It need not need any treatment. The mucosal lining of the cheek, behind the second molar teeth, there is something called as a Stensen's gland. It carries saliva from the parotid gland. Parotid gland, as you all you know, it is situated above the ramus, angle of ramus of the mandible and between the anterior of the ear. So that gland opens behind the second molar. So this examination is needed only if the patient is complaining of a dry mouth. If there is a dry mouth, there is a chance that the opening of the Stensen's gland can be blocked. Note the frenum. Any ulceration or disturbance. Frenum means definitely on the floor of our base of our tongue. That is called as frenum. Ask the patient to lift their tongue upwards to inspect the floor of the mouth. If the tip of the tongue can touch the roof of the mouth, that is very normal. If the tip of the tongue cannot touch the roof of the mouth, it is one of the diagnostic indications of tongue tie. This is the area in which an arrow is given, that is called as a Stensen's duct. Now the parotid gland palpation is seen, that we will. I'm just going to examination of oral cavity, a small demo. First of all, I will show the area of the parotid gland. This is the anterior part of the ear. This is the anterior part of the ear, and this is the angle of ramus. We can feel the angle of ramus on the mandible. So here is from here to the downward is the situation of the parotid gland. So that is clear. Now we are going in for the examination of oral cavity. Ask the patient to open the mouth. Now clench the teeth. Clenching the teeth opens up the lip and the gingival line and the condition, general condition of the teeth. Okay. Now ask the patient to open the mouth. Keep your tongue outward. So in some patients, just asking the patient to pull out the tongue, we will be able to visualize the posterior part of the oral cavity. Pull your tongue out. But in many cases, it will not be situation. So we will have to use a tongue depressor. And definitely on the surface of the tongue, you should be looking for ulcers and cracks and all the signs of the costa. We always study that the tongue is the face of the costa. Now you are going for the examination of the oral cavity with the tongue depressor. The tongue depressor should be sterilized or wiped with the proper antiseptic lotion. It should be made somewhat warm before introducing into the oral cavity. Again, we are using a headlamp. Actually, we have to use a gauze piece to hold the tongue. I am using a tissue paper instead. Now we are holding the tongue like this and pull it out. Hope it is clear. Now I am using the tongue depressor so as to press the tongue. Now I am able to just look upward, somewhat of look upward. I am able to see the posterior pharyngeal wall, uvula, and the tonsils. Now you are looking at laterally into the wall of the buccal cavity and the conditions of the teeth. Everything is visible. Now ask the patient to retract the tongue backward. Lift the tongue so as it touches the. So she can definitely lift her tongue and touch the roof of the oral cavity. And now I am looking into the frenulum of the tongue and lateral part of the base of the tongue and the floor of the oral cavity. And to look into the oral cavity, again you can use the tongue depressor to have a better view of the buccal cavity. This particular patient has a mucosal cyst on the right side of the buccal cavity. And also you can use this depressor to have a better view of the gingiva. So this is the basic examination of the oral cavity. Now it is all about pathologies. So for understanding pathologies, as Dr. Namita said during the beginning of the class, we have not gone into the operation of Roga, but we have gone into the techniques to see and analyze how the problems are to be assessed. So in case of examination of ear, nose, and the throat, we have gone through the basic techniques. Now there are further advanced techniques which comes into the specialization, which is not coming into the scope of this class. I hope I have covered the basic examination of all these three areas. Now, if you have any doubt, you can ask. Thank you.
Thank you so much, sir. The session is now open for doubt clearing. Participants can either ask your questions directly by raising the hand, or you can type in your questions in the chat box. Hello, sir.
Hello.
So the questions have started coming up in the chat box. The first question is from Dr. Sridevi. So can you please show the trans-elimination test once more? The trans-elimination test of frontal sinus.
Okay. For that, actually, the room is having a good lighting. For the trans-elimination, we have to go into somewhat, even though it is not 100% dark, there should be a dark room so that the presence of light can be appreciated. It is very simple. I have just shown the technique, and let me try here also again. Hello. Now I have switched my light off. Hope all of you can see. Now this is light from an otoscope, which is a reliable power source of light. Now I am putting this here, and please come close. Now you can see the sinus, the illuminance of the light inside the sinus very clearly. Is it visible?
So
Is it visible?
Yes, sir.
yes, sir.
Even the means cavities inside the sinus is also visible for me. Through the video, it is only this much possible. It is very simple. You can do it yourself on any other person. The presence of light can be appreciated well above the eyebrow. Okay, this is the technique, and if the videos are also available in the YouTube also, in which they are using some better video techniques, so that it will be much clearer than this.
Thank you, sir. I hope it's clear to Dr. Sridevi. Now, the next question is from Dr. Taj. Sir, in parotiditis, how can we do parotid gland milking?
First of all, the expression of pus is what is intended by Dr. Taj. And the expression of any excessive fluid from the parotid gland, so that the tension will be relieved and the pain will be relieved for the patient. For that, simply we have already shown the palpation of the parotid gland.
Sir, according to you, what all instruments should a practitioner of Shalakya Tantra have with them in their hand?
I have not completed my answer on parotid milking. So simply the gland is situated from this anterior part of the ear to the ramus of the mandible, and the opening is somewhat here on the inferior part. So we will have to milk like this simply. Starting from the anterior part of the ear towards the buccal cavity. Like this only. Hope it is clear. Hello.
Yes, sir.
Next question was on instruments. Hello.
Hello, sir. It's clear.
Okay. So instruments, first of all, I have already told you, this is a headlamp. Now even advanced headlamps with kind of elastic and LED lights are available, so that it will be only of the size of a mouse or something like that. We can even put in our pocket. It is available for 300-400 rupees in Amazon and Flipkart. If you have a group for your discussion, and if Dr. Namita can remind me, I shall send the link of that particular thing. And apart from that, I have already shown you, we need a tongue depressor, Tudicum's nasal speculum. This is a one size. 3 sizes will be available, big one and small one also. Now you have to use a tuning fork of different frequencies, 128, 256 and 512 at least. And if you are intending to remove wax, then you have to use this Jobson's horn probe. And this is an otoscope, pocket otoscope. This will be costing around 6,000 rupees. And obviously there is a need of a torch. And apart from this, this is another wax hook. This is another wax hook. This is also very handy in case of some cases of wax. The wax consistency of the wax will be totally different in different people. In hard cases, we have to use the Jobson's probe. In some cases, it will be loose. In those cases, we can use this wax hook. And also, this is the Tillis forceps, which we use for nasal packing. Actually, we missed the demo on nasal packing that we will do. This is a Tillis forceps used for nasal packing. Even without the Tillis forceps, even with a simple scissor, also we can do nasal packing. So I will just show again, remind you that nasal packing in its verbal sense means nasal packing used in epistaxis. Here, what we call nasal packing in this context is the packing of the anterior nasal cavity to create a pressure between the septum and the turbinate, so that the airway will be somewhat patent. So I will just demonstrate nasal packing also with the tissue paper. I am not using Tillis forceps. I am using the blunt end of the scissor, so that even with a cotton bud also the patient can do this in the home itself. Suppose in this patient there is a nasal deviation of septum to the right. Septum is deviated to the right means septum will be like this, and the turbinate will be coming from this area like this. So the space between the turbinate and the deviated septum will be very less. We have to somewhat create a space between that. For that, we will be putting a pressure using our concept of Sneha and Sweta. Sneha from Muruvanna. No, only Muruvanna can be used. No, you can use Dhanandar or any according to your logic. And also it should be somewhat hot, so that a Sneha and Sweta will happen. So we will be using gauze soaked in Muruvanna. Suppose this is a gauze soaked in Muruvanna, and we will be putting inside the nostril like this, layer by layer, like this, folded, you can put inside. So that there will be a feeling of a good pressure in the particular area of the nasal septal deviation or the turbulent hypertrophy in the patient. This is too much of a gauze. You just give a half centimeter of gauze to the outside of the nasal cavity and cut the rest. And after 1 hour, ask the patient to pull it out. This is from clinical experience. I am telling that this is very effective in turbulent hypertrophy and all the sneezing and allergic problems due to the DNS. we had a case of a DNS in which there was some 75 degree of at least 70 degree of deviation of the septum. It was like a spur. The patient did the nasal packing for 6 months, and he was relieved of all the symptoms like the dyspnea and nasal blockage, and also sneezing. And we have the follow-up of the patient still after 2 years. And after that, the result is sustaining, and he is very comfortable. The DNS is not at all solved 100%, but the symptoms of the patient is relieved. And the other side is that if you address the patient for a surgery for DNS, even after that, the patient is having the same problem, and not one patient, many patients are coming to us after the surgery for DNS complaining of the same thing. And even in some cases, the complaint is even more.
So related to that, a few questions. First one is from Dr. Reshmi. Sir, in DNS, only Murivenna is used for packing, or what other thyla can be used?
In the video, I saw the question and I already answered it. Dhanandara thyla can be used. Any thyla can be, even plain Tila thyla can be used. And if you have such a logic that Krida will be working in this particular case, you can use Krida also.
Sir, how effective will it be in nasal polyps?
In the case of polyp, what we do is normally Ksharakarma. But there is a concept called as mini Ksharakarma, in which you can use a thyla of cortical literature called as Nasarsha thyla. In that, one of the content is Kannaram. It is a kind of Kshara itself. So packing with that can cause the recession of the nasal polyp. That can shrink, and somewhat patency of this airway can be achieved, so that the patient will be symptomatically better. But other than that, the better option is definitely Ksharakarma itself. Next question: for how much time packing should be placed in the nose in case of sneezing due to DNS? Okay, packing is usually given for 1 hour, after during which time the patient can study or can do anything inside the home, and after that it can be removed. Even you can do 1 hour twice daily also. In initial days, 1 or 2 days, patient will be having sneezing or irritation due to the packing, but after 2 to 3 days, the patient will be comfortable, and the patient will be in satmya with the process of packing. Next question: one patient is having so much nasal bleeding daily after post-septoplasty, no effect by allopathy management and ice packing. So is any management according to Ayurveda after post-septoplasty? We can definitely think of packing. In the particular case in which there is a bleeding after septoplasty, I think packing like this may not be adequate. Usual packing into the nasal cavity with our medicines may be the best way, and also internal medication from our Raktapitta point of view. That combination can give us a result. Definitely. If both side turbinates are enlarged, how can we manage packing? Both side turbinates are enlarged means it is a bilateral turbinate hypertrophy. Definitely that will be because of an allergic reaction. And in that case, you cannot pack both the nostrils together. You will have to do it alternating, and also treat the allergy with internal medicine, so that that will respond. The packing is actually a management technique. The permanent cure is definitely by using our patya and our aushadas. We have to tell the patient to pack him by himself at home. Oh, definitely. I have at least told 50 patients to use the packing at home, and illiterate patients, even if we can educate, they can even using they can do it in their home, even using cotton buds. Can we manage anosmia by nasal packing? If it is due to the airway patency obstruction, definitely that will improve with the nasal packing. And in case of anosmia due to COVID-19, we are having a very good result with the ghanana, smelling, means somewhat fierce inhalation of from a kiri made of shundi, marija, and black cumin. This is very effective for anosmia. Can we manage leukoplakia with Ayurvedic medicine? Definitely. I am going into the management now, but I think management is what is the actual topic, and it will be covered in the coming classes. Definitely, leukoplakia is manageable with Ayurvedic medicines. Sure.
Thank you so much, sir. It is always wonderful to attend your sessions. Your commitment and dedication to the science of Ayurveda is truly inspiring to all Ayurveda practitioners. On behalf of Team CAME, I extend my humble gratitude to you, sir. Thank you so much. Thank you for patiently explaining each question. And thank you to all the participants for your cooperation. We'll see you again on October 5th. Thank you. Good night.
Thank you and good night, everyone.